Got it.
Hello, and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenour, and today I'm joined by urologic oncologist, Dr. Keith Kowalczyk, medical oncologist, Dr. Sunthee Rapisuwon, and radiation oncologist, Dr. Luther Ampey. Today's topic is prostate cancer. We'll discuss who is most affected by this disease, the signs, symptoms, and available treatment options. So if you'd like to learn more, stick around, give us a like to let us know you're watching, and share this broadcast with your friends and family. We encourage you to ask questions in the comments below, and we will answer them for you. To all our doctors, welcome and thank you for joining. We appreciate you all taking time out of your day to educate our viewers. Before we begin, could you please tell us and the viewers a little bit about yourselves and the work you do at MedStar Health? Dr. Kowalczyk, I'll start with you.
All right. Well, thanks, Sarah, for hosting this, and thanks everyone for joining in. I am the Executive Director of Urology for MedStar Health in general. And in particular, I'm the Chair of Urology at Georgetown University Hospital, MedStar Georgetown University Hospital, and a urologic oncologist. So I primarily do prostate cancer care, and this is what I focus on.
Great, thank you. Dr. Rapisuwon?
Thanks, Sarah. I am a medical oncologist at MedStar Georgetown University Hospital and MedStar Washington Hospital Center. I am a GU and melanoma oncologist, and prostate cancer is one of the GU cancer that I am taking care of. I'm also a medical geneticist by training.
Great, thank you. And Dr. Ampey?
Thank you, Sarah. I'm Dr. Luther Ampey. I'm a radiation oncologist who's been at MedStar Montgomery Medical Center for approximately 25 years now. I see a lot of prostate cancer over the years, and I'm very happy to be here.
Awesome. Thank you so much. So we'll get into our questions now. First of all, Dr. Kowalczyk, what is prostate cancer and what are some of the risk factors for prostate cancer?
So I think we'll start with the basic premise of what is cancer in general, which is cancer happens in all organs pretty much of the body, and it's just uncontrolled cell growth. So normally through the cell growth process as we age, things get, grow, they get repaired. And then when a cancer happens, there's something that went off with the repair of genes, and these cells become abnormal and they start growing abnormally, some fast, some not so fast. So cancer is just an uncontrolled cell growth of a particular organ. So in prostate cancer, we're talking about that in the prostate. So in prostate, 95% of the cancers are what we call adenocarcinoma. And that's just the kind of the basic prostate cancer. So when we say prostate cancer, that's what we're really referring to as prostate adenocarcinoma. I have a lot of patients that ask me the differences. The other less than 5% are very rare. So when we talk about prostate cancer, it's a form of adenocarcinoma, which is, a common cancer in glands, which the prostate is. The prostate in particular, people want to know what it is. Well, men have them, not women, and they are sexual glands. They're essentially reproductive glands that are right underneath the bladder. Patients may say, well, my father had prostate problems, but that could have just been enlarged prostate, difficulty urinating, and not necessarily prostate cancer. So that kind of leads into what are the risk factors, or, I guess, how do I know I have prostate cancer? So a lot of patients will say, I didn't have any symptoms, and that's common. It's not a symptomatic cancer. If it is, that's probably when it's too late and there hasn't been screening. The fact that someone may have difficulty urinating, that's not a sign of prostate cancer. That's a sign of benign enlarged prostate. The risk factors of prostate cancer, number one, is if you have a family member. And that's a primary household family member. It's not necessarily an uncle or a cousin. If you've had your father or a brother that's had prostate cancer, you're 2 to 3 times more likely to develop that in your life. Now, African American men are definitely at higher risk. They're about 2 times more likely to be diagnosed with prostate cancer during their life, but not only that, about 2 times higher risk of death from prostate cancer. So that's a problem for multiple different reasons that we're trying to solve. Another risk factor is the BRCA gene. So this is known as something that has been seen in women with ovarian and breast cancer and syndromes. We've actually seen that both BRCA1 and BRCA2, particularly BRCA2 is a little bit more aggressive, that men in these families actually have a higher risk of prostate cancer. Finally, If you don't have any of these risk factors, it can still happen. So what we started doing, and this is not necessarily mainstream, but urologists like myself, we start checking what's called a baseline PSA in patients that are 40 years old. And if you're in your 40s and you get a PSA and it's less than 1 and you have none of those risk factors, you're probably pretty safe for the rest of your life and probably don't need to be screened all that much. If it's over 1 and you have a high baseline PSA, then you are at increased risk of prostate cancer. So those are the 4 main groups that we are looking for to screen for prostate cancer to make sure we get it early. Because if it is caught early, as we'll get into, it's very, very treatable.
Yeah. Well, and then that kind of answered, I think mostly covered my next question, which was, are there some people more at risk than others for prostate cancer? And it sounds like African-American men, history in your family. Is there anything else, or did we cover all of that in
we covered it. I mean, yeah, African-American men, family history of BRCA1, BRCA2, and a high baseline PSA.
Thank you. And Dr. Ampey, can prostate cancer be prevented at all?
Thank you, Sarah. As much as we'd like to prevent prostate cancer, there really aren't any strategies that we can deploy that will prevent it. Mm-hmm. So we'll pivot and we'll talk about risk reduction instead. So when we talk about risk reduction, what we're talking about are doing things that help us reduce the chance that we might ultimately develop prostate cancer. Those tend to be, for prostate cancer, healthy lifestyle and healthy diet, essentially, very simply put. When we have healthy lifestyle, such as exercising frequently, vigorous exercise, let's say 30 minutes most days. If we eat plant-based diets, we don't have a lot of red meat. We also maintain a weight. Those types of things are risk reducers, but really we can't prevent prostate cancer. That's not something that we found any data to support doing.
Thank you. And Dr. Kowalczyk covered a little bit of this, but how does someone get screened for prostate cancer? How does that process work?
Well, the actual process of getting screened is just a simple blood test. So that's pretty straightforward. And Dr. Kowalczyk talked about some of the screening that he likes to do with the baseline. Screening has been something that's been very controversial in the last several years, mainly because from the advent of prostate screening in the mid-90s, we have discovered a lot of men who have had low risk, sort of non-clinically relevant prostate cancer. And so those men are overdiagnosed and sometimes even overtreated, meaning that their prostate cancers weren't likely to become very active or life-threatening. So ultimately, when we screen for prostate cancer, what we like to be able to do is identify prostate cancers that are significant, that are more life-threatening, some ones that we can intervene in and make a big difference. So in terms of screening, in 2018, just to give a little background, the United States Preventive Task Force actually put out some recommendations that people of average risk would start screening between 55 and 69, and people of high risk, and high risk are those patients that Dr. Kowalczyk talked about, those being African-American men, BRCA positive gene, and family history, might start in their 40s to 45. And Dr. Kowalczyk even talked about getting a baseline between 40 and 45. I think there's been a lot of nuance to prostate screening. So it's a very reasonable thing to have that discussion with your primary care physician to begin a baseline screening process, just as Dr. Kowalczyk talked about, in your 40s. And then based on the value of that, to continue to be screened if you're higher risk, or not get screened yet until you get into your 50s. For men of average risk, it's very reasonable to begin the prostate screening process between the ages of 50 and 55. And again, have that conversation about what the results are as to how frequently you might want to continue getting screened from that point on. As men get older, there is some controversy about when we should stop screening. So for instance, if one gets to the age of 70, should we continue screening? There are going to be some patients who want to continue screening, but they should also have that conversation with their primary care doctors or potentially even their urologist as to the benefit of getting screened from that point forward. So baseline screening, I definitely agree with Dr. Kowalczyk. In the 40s, average risk begin in the 50s, and then have conversations ongoing with your primary care doctors and potentially urologists about whether or not you want to continue.
Great, thank you. And so if someone has an elevated PSA level, does that mean that they have prostate cancer?
So the PSA is an antigen secreted by the prostate. And so it does have a blood level. And it does not mean that someone has cancer. It just means that there's an elevation of that protein in the bloodstream. There are lots of conditions that can actually lead to that, such as inflammation of the prostate, infection of the prostate, and even benign prostatic hyperplasia. So benign enlargement, which is what happens when men get older. Mm-hmm. So an elevation in PSA does not necessarily by itself mean that someone has prostate cancer. However, it might be a flag that there needs to be an investigation as to whether or not that should be looked at.
Okay. And then Dr. Kowalczyk, what is the prognosis for someone diagnosed with prostate cancer?
Overall, we're lucky to say that if we catch prostate cancer before it has metastasized or stage 4 cancer, the prognosis is very, very good. You can look at multiple different endpoints that you're looking at though. So survival for prostate cancer that's localized is excellent. It's 99% over 10 to 15 years. Now that doesn't mean that the prostate cancer can't spread at some point and need further treatments, but that's why we have Dr. Rapisuwon and Dr. Ampey. We work as a team in those situations to help those patients. So if you're just looking at overall survival, and prognosis is very, very good if you get treatment. If you are diagnosed later with stage 4 metastatic cancer, their survival is still fairly good, but that's a difficult one, and that's what we'll talk about a little bit later. But if you're screened and we find it, even if it's high risk, prognosis is excellent. Will you need some more? Well, can it come back? Yes. Patients are always surprised that, well, I've had it removed, I've had it radiated. How can the cancer come back? That's just sometimes how cancer works, but we have many, every year there's newer treatments coming out that we can still treat patients where it comes back or if it's spread. But our goal is always to get it early, and treat those cancers that we think will become clinically significant. As Dr. Ampey said before, the pendulum has swung. Before we were treating way too many people, people that were not going to die from prostate cancer. And in fact, there's a push to not name a low-risk prostate cancer at all. It's those intermediate to high risk that are still localized that we're really focused on finding, because those are the patients that we can cure, and those are the patients that need treatment. But overall, the prognosis is very good if you're screened. And that's why we don't want to give up screening completely. That's why it needs to be a discussion. These high-risk patients need to be screened. Low-risk or intermediate risk patients, just check every once in a while. We definitely don't have to go back to the days of checking everyone every year, but personalize the screening, because it still happens in patients that you wouldn't expect.
Right.
And we can prevent it.
Yeah, great. Thank you for explaining that. I'm going to take a break in the questions real quick and thank our viewers for tuning in. If you're just now joining us, thank you. We're speaking with several of our cancer experts from the MedStar Georgetown Cancer Institute, urologic oncologist, Dr. Kowalczyk, medical oncologist, Dr. Sunthee Rapisuwon, and radiation oncologist, Dr. Luther Ampey. We're talking about prostate cancer and the available treatment options and prognosis. We have more to talk about, so keep watching, share this video with your friends, and give us a like to let us know you're watching. And if you have any questions for our experts, please leave those in the comments below. Getting back into our questions. So are all prostate cancer patients treated the same, or is it, a patient-to-patient basis how treatment goes? Dr. Kowalczyk or Dr. Ampey?
Sure. So there are many treatment options, and it's absolutely individualized. My favorite treatment is active surveillance on low-risk patients. So we were implying this before. Low-risk patients do not need active treatment, but we watch them very, very closely to make sure it doesn't progress over the years. If we decide that somebody does need treatment, there are multiple treatment options, and it is very personalized, and they're all very, very good. To keep it simple, I'll stick with this. The gold standard is either surgery, which is what I do as a urologic surgeon, or radiation, which is what Dr. Ampey does. Those are 1A, 1B. I'm not even going to assign an A and a B, because if you look at the overall survival for both of those, patients do very, very well. But it's individualized. Younger men tend to do better with surgery. Older men over 65, 70 tend to do better with radiation, but there's so much gray area there that I hate to really pigeonhole people into that. There are other various treatments that are experimental, focal therapy, things like that. And sure, we offer those to certain patients on trial, but really it's surgery or radiation for primary treatments. For patients that are unfortunately diagnosed a little bit later when surgery is no longer an option, that's where you get into a combination of radiation and hormonal or chemotherapy that Dr. Ampey and Dr. Rapisuwon would do. So I'll hand off to Dr. Ampey to talk a little bit about that.
Yeah, and even among patients who choose radiation, there are myriad options. Mm-hmm. And there are different combinations that we can use. We oftentimes will use radiation with hormone therapy, and sometimes we'll do radiation after surgery as well. So as Dr. Kowalczyk has said, not all patients are treated the same. They're treated extremely individually. There usually is a big discussion that we will have with the patient in terms of what their goals are. Some men are averse to surgery. Some men want their prostate removed. Some men would like to have radiation. They think it's less invasive. So we take that all into account as well. So it's a very much a give and a take in terms of our discussion with patients.
Thank you. And Dr. Ampey, when someone is diagnosed with prostate cancer, how do you all work together to treat that patient? I know Dr. Kowalczyk mentioned that you guys work together with treatment. So can you tell us a little bit about that?
Absolutely. Well, with many patients that we manage with cancer, it's a multidisciplinary approach. And as Dr. Kowalczyk has intimated, there are so many treatment options that a patient can decide upon. So if a patient comes in with localized disease, they have the option of going down the surgery route, the radiation route. We look at a lot of different factors. One of the things that I know Dr. Kowalczyk and I believe in is making sure that patients have a consultation with both urology and radiation oncology, so that they can hear what the options are. Some patients may not even know what they prefer, and some patients may not even know what the logistics are of getting one modality or the other. So in working together, we make sure that patients are fully informed. It's not sort of him or me or them or us. It's more making sure that the patients are fully informed, comfortable with their decision, and ready to move forward with whatever that might be.
A backpack on that. If I ever see a patient, I always ask them if they've seen a radiation oncologist yet, even if they're strongly leaning towards surgery, young, 50 years old. I want them to know that they've made the exact right choice for them. So if anyone's out there and someone's pushing them into a treatment and only talking about one treatment, that's the absolute wrong thing, because there are so many different options, and you should see at least a urologist and a radiation oncologist, or at least have been explained that there are multiple treatment options. You shouldn't be pigeonholed into one.
Right.
And some patients are actually very surprised when we actually recommend that they see the other specialty. So if I say, I'd like you to see the surgeon, they're like, well, I don't want surgery, I want to have radiation. I think you should see the surgeon anyway, because you don't know whether or not you might want to have surgery. There might be something attractive about that particular modality that you'd like to hear about.
Yeah. So kind of related to that and going into our next question, we have a question from one of our viewers, Rosie, and you all touched on this a bit, but why choose surgery over radiation? And then one of my questions is, are there any new surgical treatment options coming soon, or that have just, you guys have just started using? I'll give that to Dr. Kowalczyk or whoever wants to answer.
I guess, yeah, if I do the surgery, so what I tell everyone when they come into my office with prostate cancer diagnosis that needs treatment, localized, meaning it hasn't spread, we're having a discussion to see whether surgery or radiation is for you. I wouldn't necessarily say that there is a reason for everybody universally why you should get surgery over radiation or vice versa. Mm-hmm. In general, I think the overall survival outcomes are the same for both. I want to put that out there right now. Mm-hmm. But it's the little details that might attract one patient to surgery versus radiation. So a lot of men that are in their 50s, they have a long life to live, and the risk of recurrence needing further treatments is real. And there's some data to suggest that recurrence in those men, not in older men, but in younger men, may be less with surgery, and maybe. So those are the patients that may be better off with surgery. The older patients that are in their 70s, don't want to go through the surgery, maybe aren't healthy enough to have the surgery, radiation is a very fine choice for them. Sometimes men may need hormonal therapy with their radiation if they have a higher risk disease, and that's decreases testosterone, also has side effects. So they may not want to do that. So that's why it's a very long discussion. That's why you have to see the urologist and the radiation oncologist so you can see what fits best into your life. As far as new surgical treatments, there's new, everything's better now than it was when I was training. So as far as surgery, pretty much every surgery is done robotically. All that means is an easier recovery, home the same day or maybe the next day. I've been really pushing what's called pelvic fascia sparing prostatectomy. Probably one of the highest volume surgeons in the country doing that and pushing that. What that has done has reduced the risk of urinary incontinence or leakage of urine after surgery. So patients have been doing much, much better with that approach. And that's what I favor. So that has made surgery, in my opinion, much more appealing because urinary incontinence is a devastating side effect. I'll hand over to Luther to kind of fill in any blanks that I left.
One of the things that patients have said to me in terms of why they chose surgery was that obviously when you have surgery, you have the prostate removed. And so anytime the prostate is removed, the pathologist has a greater opportunity to fully evaluate the disease within the prostate. And there potentially would be more information than just having a biopsy. That gives a little bit more certainty to some men in terms of how much disease they had. So they feel much more comfortable with that. Mm-hmm. Some people choose radiation because they don't want the invasive aspect of it. And they feel like they don't want to take a risk of having incontinence. Dr. Kowalczyk's talking about the surgery that he uses and the low incontinence rate. Radiation does not have much by way of incontinence. It's almost 0%. Mm-hmm. Patients will get some urgency and some frequency, but certainly incontinence is not something that's on the roadmap. So it is very personalized, and how a patient decides he would like one or the other really comes down to the discussion and what the priorities are for that particular patient.
Great, thank you. And thank you for your question, Rosie. Dr. Kowalczyk, I think you've mentioned a couple of these, but are there any side effects to, or before I get to that question, sorry, what are the benefits of minimally invasive surgical options, and what are those options?
I mean, we're talking really one, which is robotic prostatectomy. That's what we talk about when talking about minimally invasive surgical options. It's robotic prostatectomy. There are different techniques, as I was alluding to, the standard prostatectomy, which has a little bit higher incontinence rate, versus mine, which is the pelvic fascia sparing prostatectomy. But the main benefit is the debilitating, well, I would never say an open surgery that's not minimally invasive is that debilitating, but it usually consisted of a 2 or 3 day hospital stay, more pain, much higher risk of blood loss. Now that we do it robotically, blood loss is like not a thing. No one gets transfused. Before, when we were doing open surgery, which is a long time ago, some people still do it and they do it well. I don't want to put them aside, but the transfusion rates were sometimes up to 20%. Now that just doesn't happen. Pain is very minimal. We don't need to give narcotic pain medicine anymore, and we've started sending people home the same day. So that's really transformed how people see surgery. And we've been able to minimize the incontinence rates to basically less than 1%. The thing that all men have to consider, though, is any treatment, whether it be surgery, whether it be radiation with hormonal therapy, sexual dysfunction. And that's harder to preserve in surgery. I've had patients that should have, you think should have a perfect outcome as far as their erectile function goes, and it's not. And I've had patients where I think there's no way they're going to have erections and they're fine. So a lot of that depends on the stage of the disease. If someone has a high stage disease, we don't want to spare the nerves, because then that risks essentially leaving cancer behind. So, but when we're talking about any treatment, it's sexual side effects and urinary side effects. And thankfully, and same, as I'm talking about, all of the advances we made in surgical therapy, there's tons of advances in radiation as well. Shorter treatments, less side effects, more precision. So I think both ways, looking back 20 years ago, we're so much more advanced in minimizing these side effects, but this is all part of the discussion that we discuss with patients, because it can be very life-changing for some people.
Yeah, thank you. Dr. Ampey, what types of radiation therapies are available to best treat prostate patients?
Yeah, that's a long list. Actually, fortunately for us, as Dr. Kowalczyk just alluded to, the goals of radiation therapy to treat prostate cancer are fairly straightforward. And that is, we're trying to deliver a very high dose in a very focused manner to the prostate and sometimes the lymph nodes. In doing that, we also want to make sure that we can eliminate significant dose to neighboring structures, those being the rectum and the bladder. And there are a number of ways that we can do that. Certainly in MedStar Health, we have systems such as CyberKnife, which can deliver a high dose treatment in a very focused way over a very short period of time, meaning 5 treatments over a week. We also have treatments such as proton therapy. Proton therapy has the same biologic interaction with tissue, but it has a physics advantage whereby when the beam enters into the body, it doesn't release energy until it gets to the depth it's programmed to get to. Therefore, we can actually spare surrounding tissue and have a very highly focused treatment to the prostate. We also have image guidance. We have IMRT. IMRT is intensity modulated radiation therapy, which means we can use a standard or conventional linear accelerator. Those are more commonly available out in the community. And we can shape the radiation so that we can miss critical structures such as bladder, intestine, rectum, and we can treat the things that we want to, such as lymph nodes and the prostate. Do it all under real-time guidance so that we know where the prostate is located on that particular day at that moment, because the prostate can change position depending on how full or empty the bladder is or how full or empty the rectum is. So all of those treatment options end up with the same result, which is a very highly focused, accurate, very safe way of delivering radiation therapy with great efficacy.
Just want to add one thing. CyberKnife, I get a lot of questions about CyberKnife, and people think it's surgery because of knife. And I just want to clarify that is radiation therapy. So when we talk about whether people are surgical candidates or radiation candidates, that's the first decision. And then Luther will talk about all of those things, including CyberKnife, as which one of these is best for you. So I think that's a clear thing that I want to clarify, is that CyberKnife is not surgery. It's a form of radiation. Right.
Yes. Yeah. Thank you for clearing that up. I definitely thought it was surgery when I first heard of it. You're right. The knife.
Yeah, I've asked for some changes in next year's campaign, but
yeah. And then Dr. Ampey, are there any side effects to any of these treatment options? Do different ones go with the different options, or can you explain those a bit?
Yeah, the side effects of radiation tend to fall in 2 buckets. And I usually tell patients those are what I call plumbing. If we think about radiation only affects where we aim it. So it's not going to go through your body. It's not going to affect your hair. You're not going to have hair loss, things like that. So if we think about the anatomy of the pelvis, the prostate is tucked underneath and right beside the bladder, in front of the rectum. So those would be the major organs that get affected with radiation. So the usual side effects would be increased urinary frequency. And again, remember, the urethra goes directly through the prostate. And so a lot of these side effects are because we're affecting the urethra. So urgency, which means that when you got to go, you got to go. You can't wait for the commercial break, you got to go. Frequency, you're going to urinate a little bit more during the day, potentially at night as well. And sometimes at night, when you get up to go, you really don't have much urine to pass, but you do have the strong feeling that you have to go. Sometimes patients will have the sensation of incomplete emptying, where you've gone and then you got to go back 5 minutes later to empty some more, or they might even have slow onset of their stream. In terms of effect on the rectum, there are a couple of things that we're able to do nowadays mechanically to move the rectum out of the way. One is to inject a hydrogel, so it acts as a spacer between the prostate and the rectum, so that we get a lot less dose to the rectum. And then with image guidance, we're able to make sure that we can focus on the prostate, eliminate a lot of the rectum, block it out, so that rectal issues are far, far, far less than what they used to be even 5 or 10 years ago. So the main constellation of side effects really come down to plumbing, and that's what I talk to patients about.
Great, thank you. And we have a question from one of our viewers. Do you use the Decipher test to help guide the decision on the treatment?
That's kind of in my bucket. Very rarely. So what Decipher is what we call genomic sampling of prostate tissue. So once we get a biopsy, we can send that prostate tissue off to another lab that then runs. So they look at 22 basically mutations of genes that are associated with either a slow-growing prostate cancer or fast-growing prostate cancer. It's my belief that if your biopsy shows low-risk prostate cancer, the Decipher test is not going to change much. If it shows high-risk prostate cancer, you need treatment, the Decipher test is not going to change much. It's in the middle. It's those patients that are straddling that line between, is it low risk, can we do active surveillance, or is this going to progress? That's where I would get the Decipher test. And there's a few others, Prolaris and Oncotype, which are similar. So that's where I use it, is when I'm trying to decide whether a patient can continue active surveillance when they're kind of teetering away from the low risk category. Other than that, it hasn't been shown to necessarily affect outcomes such as survival and how you do. So I don't run it on everybody. I'm very selective with who I run it on.
Okay. Thank you for explaining that, and thank you for your question. Dr. Rapisuwon, when would someone require medical oncology for prostate cancer?
So medical oncology will get involved in their care not only in the setting of advanced prostate cancer, but we will also do help maximizing the treatment efficacy in a localized setting as well. For example, an unfavorable intermediate risk prostate cancer, high-risk prostate cancer, very high-risk prostate cancer, as well as the local recurrence of prostate cancer as well. So the treatment will be given either after or in combination with other treatment modality.
And then what type of treatment options are available?
There are multiple treatment options from medical oncology in the standpoint to treat advanced prostate cancer. First is a hormonal therapy, which is a mainstay of treatment for advanced prostate cancer. So this treatment involves a medication that blocks the production or action of male hormones, such as testosterone, that would have stimulated the growth of the prostate cancer cell. Then there's chemotherapy. So chemotherapy in prostate cancer are generally well tolerated and very efficacious, and are often given in combination with hormonal therapy. So next one is the radioactive drug or radioligand drug. In this situation, we have both radium-223 and more recently, lutetium-177 PSMA. So radium-223 will deliver a particle to a very limited area of prostate cancer in the bone, while lutetium-177 would deliver a particle radiation selectively to prostate cancer cell and the surrounding microenvironment. And lastly, the targeted therapy. So this type of treatment will aim for the tumor that has a problem with DNA damage repairs that Keith previously alluded into. For example, people with BRCA1, BRCA2, and other genetic mutation, or people who don't even have those BRCA1 and BRCA2, but their tumor has DNA damage repair. So this therapy will target those cells and will shrink the tumor or stop the prostate cancer cell growth.
Okay, thank you for explaining that. And are there any new treatment options or clinical trials available?
Oh, there are multiple of that. So the most recent one is lutetium-177 PSMA that we mentioned about, while we're still waiting for the result of the immunotherapy clinical trial, and also the combination hormonal therapy and targeted therapy as a frontline treatment, or adding the lutetium therapy to the frontline treatment. We also have the immunotherapy that would attract the immune cell into the cancer cell that we call bispecific antibody, for example, or the drug that would interfere with testosterone signaling, or the newer radioligand therapy, or the drug that will degrade the specific antigen receptor that we call ARV7 on the cancer cell, and the list goes on and on.
Great, thank you.
I have to
There,
backtrack on that, not backtrack, but add to that, that it's a very exciting time. And I mean, no one wants advanced prostate cancer, obviously, but that's what I was alluding to is it seems like every 3 months, there's another landmark paper in Dr. Rapisuwon's area, medical oncology, where they're just changing the paradigms of how we're treating these cancers and how well we're able to treat these patients with combination therapies, targeted therapies, things like that. It's literally every 2 months there's something new coming out. So, and you know, it's a very exciting time.
Yeah, that's great to hear. Dr. Rapisuwon, are there any side effects to any of these treatments?
Yes, they all do, but they're all manageable. For example, the hormonal therapy often leads to hot flashes, decreased sexual drive, joint or muscle discomfort, increased testosterone or blood pressure. Well, the chemotherapy has the usual chemotherapy side effects, while radioligand therapy and targeted therapy can decrease blood count and other side effects. However, these side effects can be minimized and managed by medical oncologists and their team to tailor the appropriate treatment and dosing to the patient so that these side effects can be prevented or at least minimized.
Great, thank you. And Dr. Rapisuwon, I'll ask you this, but Dr. Ampey and Dr. Kowalczyk, if you have any additional input, please let us know. But after diagnosis and treatment, can men lead a normal life?
So I can describe our experience from treating patients with advanced prostate cancer. So our expectation is that our patient would lead as normal life as they did before they had the cancer. Of course, some lifestyle change may happen, but it is similar to other chronic disease like hypertension or diabetes, as our goal of treatment for prostate cancer currently is to change the cancer that would have otherwise killed them into a chronic disease that they can live with and control the disease well. So from what we see, a lot of our patients have led a relatively normal life while they're living with prostate cancer. So Luther and Keith, anything to add on?
I think one of the things I like to sort of differentiate in terms of using the term normal life, I think people can live extremely active, full lives. Certainly, as we touched on, there are some side effects that can be residual after treatment. And some of those can be sexual dysfunction. Some of those might be incontinence. Some of those might be some change in the way their urinary habits are. But certainly men can definitely lead a very active, full, and complete life, but there may be some residual that happens. But we have a great opportunity, particularly in patients who have localized early stage disease, to provide them a very long cure rate.
Yeah, I think Luther put it perfectly. Men that we treat, you know, if you saw them on the street, you would not know that you had cancer. Your hair is not going to fall out. You don't get weaker. You can live a very normal, active life for sure. I think one of the most important things we need to do as physicians is also set expectations as to how that will go. So once you have treatment, there will be immediate changes, just like any surgery that you have. And I broke my leg and, you know, I'm limping. So, but it's going to get better. So patients that have had radiation, as Luther said before, they're going to have a little bit of urgency during that, but it should get better. Patients that had surgery, they may have a little bit of leakage of urine, but that will get better over time. I think sexual function is the one that I really try to be very realistic with for patients, so that to set expectations. That's the biggest change probably. That doesn't mean that they cannot be sexually active with partners or intimate. It may be a little bit different, and we have multiple treatments to help there. But certainly a lot of patients, we can get back to normal function. Many we have to work with, but a lot of it is setting expectations. But the bottom line is, yes, you will get back to being a normal, healthy, active person with some changes that hopefully we counsel enough that the patients are ready for it.
Yeah, that's great to hear. Thank you. So my last question for our experts is, what message do you have for our viewers to take away after watching this broadcast with us? I'll start with you, Dr. Rapisuwon.
So having prostate cancer is definitely a life-changing experience, but definitely not a death sentence. They can be treated even with advanced prostate cancer. They can still be treated and have a relatively as normal life as possible.
Great, thank you. Dr. Ampey?
One thing I wanted to emphasize is, I think Dr. Kowalczyk said it early on in our discussion, is that 9 out of 10 gentlemen, and even probably higher than that, will be alive and thriving 10 years from the time that they're diagnosed with prostate cancer, which means that we have an excellent opportunity to diagnose disease, treat disease, and have men lead a very, very full and healthy life.
Great, thank you. And Dr. Kowalczyk?
Yeah, I think my main thing that I tell everybody is that there's a lot of controversy around PSA screening that has scared people away from getting screened. And the importance there is, number one, in 2018, the recommendation to not screen was reversed, but there was not as much press about that, especially for the patients at risk, African-American, family history, BRCA1, BRCA2. You should be screened every year. The other thing that I hate hearing, even though it's partially true, is that, you know, many men will say, well, I heard that nobody actually dies from prostate cancer. And while if you're not treated, that's not true. It is still the second leading cause of cancer death in men, and that's mostly with advanced prostate cancer in men that weren't screened. Is it true? I mean, it's also the most, second most, non-cutaneous malignancy in men. So there are so many cases of prostate cancer, and it may be true that half of those men will never die from prostate cancer, but half of them will have a serious prostate cancer that we need to check and we need to find. We are no longer in the mindset that every prostate cancer needs to be treated and suffer these side effects. So what I would say is, don't ignore PSA screening. It can save lives, and you can lead a normal and happy life. Even if you are diagnosed with prostate cancer, it could be low risk, and you do not need to be treated. Just watch closely as almost a chronic disease. So it's one of those things where absolutely most men are not dying from prostate cancer because they're screened, but there's a very real possibility of bad things happening if you don't get screened. So that's the bottom line, is I'm really trying to reverse that message that was put out now 11 years ago.
Yeah, thank you. Well, I think those are all perfect messages to wrap up this broadcast. Thank you so much to our doctors for joining us and answering our questions. And thank you to all of our viewers for watching and sharing your questions. For more information or to schedule an appointment, you can call 202-295-0513. We'll be posting that phone number in the comments as well. Thank you for joining again, and we'll see you next time.
Thanks, everyone.